Excellent. Hello. I've definitely met Claire, but anyone who I haven't met, my name's Ian. I'm one of the staff specialists. And I'm just going to talk briefly about Pre-FEISTY II, which is a trial that feels like it's been in the making for a very long time. I've got the impression that it's going to be one of those things that one day we just suddenly go like, yep, we're starting it tomorrow. But I've also got this nagging doubt in the back of my mind that it might not all come off for various reasons. But essentially, it's probably going to start within the next couple of months. And so we just wanted to make sure that as many people as possible are aware of it, whilst bearing in mind that for anybody who's not here, who's clearly not going to hear this message, there's also going to be a VLE for everybody to have a look at as well. So in terms of background, everybody knows that injured people bleed. We don't know, in an ideal world, if you bleed, you clot so that you stop bleeding. And unsurprisingly, when you bleed and you clot, you use up all the stuff that helps you to clot. And so if you continue bleeding, you get coagulopathic, you don't have any clotting factors. Fibrinogen is one of the clotting factors. I might have a picture somewhere of, a fibrin mesh and some platelets and stuff like that, but I've got to say, I don't deeply understand the clotting cascade. I just know that fibrinogen is one of the clotting factors that drops down lowest and is demonstrated to be associated with higher rates of death. And so in theory, if you replace fibrinogen, you can reduce the amount of bleeding, you can reduce death, probably. And ITEM have kind of got quite interested in this. So for anyone who doesn't know, the Institute of Trauma and Injury Management is a state-level organisation that kind of looks at trauma from a, sort of like strategic level across the state. And they've got a trauma innovation committee that a few years ago made this recommendation, which is that fibrinogen concentrate should be considered as a pre-hospital fibrinogen replacement, but that should be done ideally within a clinical trial. And we've been trying ever since that statement to get the clinical trial up and running. And I won't bore you with all the background to all of that. This also came off the back of a coroner's recommendation. So there was some poor guy who I think got stabbed in the axilla or somewhere, way out and bled to death. And one of the coroner's recommendations from that was that retrieval services should look at ways of bringing clotting factors into the pre-hospital environment. So fibrinogen concentrate is one option. There's also another spoke going on where we're looking at whole blood potentially. But yeah, that's the background to why we're looking at it, and it's taken quite a long time. So what we want to know really is, by giving people fibrinogen concentrate, when they've got what we think is major bleeding, can we get their fibrinogen level up to the level of more than 2 grams per litre, which is, nobody really knows what the ideal is, but more than 2 grams per litre we think is probably associated with a reduced death rate, and that's compared to no supplemental fibrinogen. On the one hand, you'd think that's really obvious when you give people fibrinogen and then you measure their fibrinogen level once you get them to hospital. Almost certainly you would expect that it's going to be higher, but we don't know that that's the case, particularly in our system where we've got quite long transport times. But anyway, that's the question. In terms of fibrinogen replacement, for everybody who's worked in hospital, I'm sure you're all familiar with cryoprecipitate as being the main way that we give fibrinogen. But there's also lyophilized fibrinogen concentrate, which is basically a recombinant product. It's got advantages, obviously, over cryoprecipitate. Cryoprecipitate you can only have out of the fridge for something like 6 hours or something before bad things happen to it. I don't know what they are, but I know that it's not a practical thing for us to use. Fibrinogen concentrate's got something like a 5-year shelf life when it's stored at the right temperature. That is one slight drawback, is that we have to have an ESCI, but we'll talk about that again in a minute. From our perspective, if you're in a retrieval environment, the only real way that you can give fibrinogen concentrate typically, you can give fibrinogen supplementation typically is by using fibrinogen concentrate. Occasionally, for anyone who's given an RTP, you may have opened the ESCI and seen several bags of cryoprecipitate and been delighted to see it. So it's not impossible to give cryo in the pre-hospital environment, but it's not possible to do it as a routine thing. So how do we get here and what are we trying to do? So you've probably heard of FEISTY and FEISTY II because they've been very good at social media and telling people what they do. So FEISTY was a pilot trial looking at early fibrinogen supplementation in severe trauma, just look whether or not it was practical. And now they're doing a multi-center study which is comparing cryoprecipitate with fibrinogen concentrate to see whether one or the other of them results in better clots and more stable clots. We would kind of like, and we've been in touch with the FEISTY II investigators, we'd quite like to be able to have a pre-hospital arm of that study. And they're very supportive of that and very keen to have it. But the drawback is, we know from Patch that actually research in the pre-hospital environment, particularly with a critically bleeding patient, is really difficult because it's such a busy environment. And so if you look at Patch, we only managed to recruit about 50% of eligible patients. And Patch was a really straightforward study. You know, basically, if you were giving someone blood, you had to open up a vial of what was either tranexamic acid or placebo, give it to them and tell the people in hospital that this was what you'd done. Whereas, as you'll see, in what we're planning on doing is a little bit more complex. And we're not actually certain that we can logistically do what we're hoping to in the pre-hospital environment. So we've got a few questions. So question one is, in our setting, is it going to be feasible to give fibrinogen concentrate in a pre-hospital trauma patient? Question two is, if what we're hoping to do, like the blood, where once we open the SCI, if we don't use a product, it basically gets wasted. It's going to be similar with fibrinogen concentrate. And so we're using a 3-gram universal dose. And what we don't know is whether or not that's going to be adequate to get the fibrinogen response we want to in all comers. So we want to know, effectively, does the universal 3-gram dose actually work? And then we also want to know whether or not it's feasible to do in-field randomization using a smartphone app. So those are the kind of 3 questions that we've got. Usually, the ideal would be for most studies that, you're going to look at a patient-centered outcome, like, does this actually result in fewer people dying and all the rest of it? And that's, often one of the criticisms, if, you listen to people on podcasts and stuff talking about research and, well, of course, this is a terrible study because they didn't use a patient-centered outcome. The problem is, to get to those studies where you're doing patient-centered outcomes, you have to do a bit of spade work so that you know what you're talking about. And this is one of those studies which is doing the spade work for hopefully future work. What we're planning on doing is a slightly unusual design. So it's a 2-phase design. In the first phase, what we're planning on doing is every patient who gets enrolled, we'll talk a bit about how we enroll people in a minute, every patient who gets enrolled gets given fibrinogen concentrate. And in this part of the study, we're just testing whether or not we can get an adequate response. So whether or not, if we give people 3 grams of fibrinogen concentrate, do we get people arriving at hospital with their fibrinogen level in a near normal range? Good. This is a fairly small study, only going to be 23 people in that arm. But what we'll do at the conclusion of that phase is just analyze whether or not we've got an adequate response. And we've said that an adequate response is that 40% of participants have got to have a fibrinogen level of greater than 2 on arrival to hospital. If we find that that doesn't happen, then we're back to the drawing board, because there's probably not any point going on to the next stage. If we find that that does happen, we're going to move to the next stage, which is a more conventional RCT. And again, it's a small study with kind of like 15 people in either arm, and that's testing really the randomization. But by using this kind of study, we'll end up with a bigger control group. So we'll end up with 38 people in the control group, 38 people in the group who got fibrinogen, and then we'll have the other people in the RCT to compare them to, which actually adds a bit of power. I won't bore you with the stats, but I think it works. And what we're looking for there is the feasibility of whether or not we can randomize. Because if we find, we're hoping that some of these patients are going to be in slightly more remote areas. And if we find that actually smartphone app doesn't work because our connection doesn't work and all those kind of things, that'd be something else that is a snag in terms of the future. And also just bandwidth, so even if you've got perfect connection, everything else works, but as a team, you're so overwhelmed that you can't manage the randomization in a reasonable proportion of patients. That'd be another reason not to take this further forward. In terms of inclusion/exclusion criteria, so the inclusions are relatively straightforward. You've got to believe that the patient in front of you is an adult. Okay, so it's not impossible you could get that wrong because some of our patients are, unknown to us, so we may not, but they've got to appear to be an adult. They're going to be suspected of critical bleeding, in your opinion. Okay, and they've got to have planned or ongoing pre-hospital blood transfusion. So if you think they're bleeding, but you're like, I don't need to give them a transfusion, you're not going to involve them. And they've got to be going to one of the participating trauma centres. And I'm not going to give you a whole list, but there are about 8 different participating trauma centres. In terms of exclusion, so if you think whatever happens, they're going to die, we don't want them in. Okay. Randomization can't occur within 6 hours of injury. That would be rare in our circumstances. If they're known to be pregnant, you might not know about that. If they're known to have a genetic or drug-induced coagulation disorder, don't enroll them, but you probably won't know about that. Known objection to blood products. So for someone on scene saying, no, he's a Jehovah's Witness, he would not want a blood transfusion. There were some ethical issues about that, but from a study perspective, it's really straightforward that you can't enroll them. And if they've already had some fibrinogen concentrate for some reason, which would be vanishingly rare in our system, and if they're already participating in a competing study, but you're unlikely to know that in all honesty. In terms of what we do, it's important to say that everybody gets, their standard care as a priority. So, they get their primary survey, they get whatever hemorrhage control you're able to offer them in the field, vascular access, airway management, etc. Make sure you've got all of your ducks in a row before you move on to the next part of the study. But one of the key parts is that you don't have to worry about informed consent. So the rationale is all these people are critically bleeding, a lot of them are unconscious, none of them are in a position to take on board a consent discussion and give prospective informed consent in a meaningful way. The ethics committee is given permission for a waiver of consent, so you don't have to worry about that. We've got an app that, part of this study is testing. And basically it'll go onto the paramedic smartphone, okay, and this is going to allow you to put in basic patient demographics. You'll be able to check their inclusion and exclusion criteria off. It'll generate a study number for you. In the first phase, it will just say, give the patient fibrinogen concentrate. In the second phase, it'll either say they get standard care or they get fibrinogen concentrate, and you just follow the advice that you follow the instruction you're given by the app. The only reason I've got a bright yellow square on here is just to remind me to tell you. So the fibrinogen concentrate is going to be kept in blood eskies, and that's one of the delays to starting, just sorting out the blood eskies, which is something that we're just resolving at the moment. It's surprisingly expensive, it turns out. So they'll go in blood eskies. What we're saying for this is that we really want to recruit people on longer missions. So, most of the road primaries that we do locally, where you're in hospital, relatively quickly, you probably aren't going to have time to draw up and give fibrinogen concentrate. And so in the main, we're envisaging this being an intervention that's offered to people typically on helicopter primaries. And the yellow thing there is to say, if you're taking the yellow blood box with you, take the fibrinogen concentrate esky as well. That kind of makes sense. As I say, in the first single arm, everybody's going to retrieve treatment. You'll draw up and administer 3 grams of fibrinogen concentrate. And as I say, that's a pragmatic decision. Ideally, people get 70 milligrams per kilogram, but it just made sense to just give everybody the same dose. So a few people will get less than 70 milligrams per kilogram, but I think no one's going to get overdosed. It's a slow process drawing it up, and that's one of the problems. So in patch 2, you just had to draw, 10 mils of stuff into a syringe. this is quite, from what I gather, quite a tedious process of drawing up fibrinogen concentrate. I don't know how many people have done it in theatre, but it doesn't sound like great fun. And it's probably one of those to be done in transit. It gets administered via a pump, but it can be administered relatively quickly once that's done. And if you've not completed the infusion by the time you arrive to the trauma centre, just complete it there. Okay. But once it's done, the whole infusion probably takes about 15 minutes. Really important, and I'll emphasise this again on another slide, really important to prompt people to measure a fibrinogen level at the receiving hospital. We know from Chris Partiker and Scott Farrington had done an audit at Liverpool, and we found that fibrinogen levels were recorded only in about 40% of people, and that was in a code crimson situation, so the really sick people. So really important to prompt them to do a fibrinogen level. This will be just there in a bit more detail in the VLE, so I'm not going to bore you with it, but that's basically how you draw up the thing. It's pretty similar to how you draw up tenecteplase to give thrombolysis, in all honesty, is the most obvious analogy, and I think probably most people have done that at some point in time. It's important that you swirl it, not shake it, apparently. So it's very James Bond. And apparently each vial contains about 1 gram. But there'll be Brian is today doing a little video to show everybody how to do that. After stage 1, we'll do a data analysis, find out whether or not we've had an adequate response, and then we make a go decision about whether or not we go over to stage 2, which, fingers crossed we will. As we said, RCT phase, same, except that there's the extra step that half of the patients will just get standard care and the other half will get standard care plus fibrinogen concentrate. And again, please, fibrinogen levels on arrival. I know these are really busy jobs. You're often quite keyed up and a bit tense in handover, but it's really, really important if they've been involved in the study that they get fibrinogen level on arrival. You will all get sent this at some stage. We're just finessing it. So this is our VLE, which just takes you through, the rationale for the study, what the study procedures are again, a little bit, you see Brian's video about how to draw a fibrinogen concentrate. It's pretty quick to go through. It's not a desperately complicated study. And, if you've got any questions, having done it, you can always get in touch with me.